I want to thank everyone for joining us. Good morning. I'm Erica Blanton, and I'm the Acting Executive Director at Palisades Village. This presentation is most timely, and thank you, MaryAnn, for providing us the opportunity to learn more about Medicare and Medicare Advantage. We're here at Palisades Village dedicated to building an engaged and supportive community, and we can all use a little help understanding the complexities of our healthcare system. MaryAnn Griffin is one of our volunteers, and I don't know what we would do without her. She has led a long career in very senior level positions in a variety of healthcare settings, including hospice and home health and acute care settings and managing physician practices. 5 years ago, she retired as the Division Director of Aging and Adult Services for the City of Alexandria. And she recognized that enormity and complexity of the healthcare decisions that we all face. And so she started her own private practice, Griffin Healthcare Solutions, to work with clients one-on-one and to do training for various organizations. She's going to share her vast knowledge and experience with us over the next few months in a series of workshops that she has entitled Protecting Your Most Valuable Asset, Your Health. So without further ado, I'd like to turn it over to MaryAnn and tell us about Medicare.
Good morning, everyone. I want to bring my slides up, but just 1 second here. There we go. Erica, should I put myself on speaker view? Because right now all I see are the slides.
Excuse me, I have a phone ringing that should not be. Should be able to. So
I do.
Sorry about technical difficulties here. Go ahead and share your screen.
Okay, I just did.
We can't see it yet.
Okay.
There we go.
Okay. Sorry for the little blip on the screen. Good morning, everybody. It's lovely to be here with you. We have so much information to cover today. I wanted to know if perhaps as we go through this, if you'd be willing just to write your questions down, maybe, and maybe note what slide we were talking about, because there's just so much information to cover that I think we need to just get on a roll here and start going. So Erica, thank you so much for the really lovely introduction. I am going to try to do slideshow here from the beginning. How's that? Can everybody see the slides? Yes, thank you. Okay. All right. We're going to spend the first probably 10 minutes or so just reviewing the Medicare basics, because Medicare is one of those things that one is tempted to sign up for and then forget about. So we're going to go through the A, B, C's, and D's in the very beginning, and then we'll move into some more detail on each one of them. There we go. Okay, as most of you know, Part A, for many of us, we signed up a number of years ago for this, and it's the importance of A is going to be that they cover hospital stays, which any and all of us might have a need to do, as well as home health care. Part B takes a little bit more explanation, but Part B is all the outpatient services, including physical therapy, physician, mental health counseling, etc. Medicare C, which sort of doesn't resonate with anybody, like what is C, but that's the new Medicare Advantage plans. And we're going to spend some additional time on those because they are new, and I know people would like to know more about them. And then Part D is drugs. So let's move on. As I'm sure that you all know, you can enroll online when you're turning 65 in Medicare A. Excuse me, I'm also hoarse, which doesn't help. If someone is still working when they're 65, they they don't have to sign up for Part A as long as they have employer coverage. They can wait till the coverage is no longer available. But I jokingly tell people, it's probably not a bad idea, since there's no premiums to pay for this, if you go ahead and sign up, simply because then you can get a senior Smart Trip Metro card, and you can save $1. So that would be worth it by itself. So what does Medicare A cover? Well, the word skilled is what I would like you to come to mind on acute care hospitals, skilled home health. And I'm actually going to do a session in a few weeks called home health versus home care, because there's a really big difference in those two, and there's a bigger difference in who pays for them. Part A would cover if somebody fell, fractured their hip, had needed to go to an inpatient rehab facility, and then also covers mental health and substance abuse. The Part A part that I think we all need to know a little bit more about, and that is what Medicare pays for a hospital stay. Over the past probably 7 years or so, Medicare has come down really hard on hospitals, and physicians have to work really hard to justify admitting somebody to a hospital. It has to be what they call medically necessary, and hospitals can lose all the reimbursement from an entire stay if by chance the person can't be justified as medically necessary. But if you are admitted to the hospital, your out-of-pocket cost is going to be $1,400. And then at that point, once you've paid that deductible, if you're in the hospital anywhere up to 60 days, there is nothing else that you have to pay. However, if you were there beyond 61 days, then you end up with a payment of $371 a day. But I would tell you, I don't know a single solitary soul who's ever stayed in the hospital over 61 days. But in case somebody had, that's what you would pay. And most of the Medicare supplement, the Medigap plans, will cover that $371. So B is really important, and I don't think some people realize how important it really is. It's 80% of skilled nursing and outpatient physical health. With Part B, similar to A, you should sign up when you turn 65 or when you no longer have employer coverage, and that can be your own or your spouse's. Medicare B has a monthly premium, which is tied to someone's income. And while technically signing up for B is voluntary, and I use that in quotation marks, if someone doesn't sign up for Part B when they're first eligible to do so, and they decide at a later date that they really want it because the costs that they're incurring are just too great, they end up paying a penalty of 10% for every 12 months that they could have had Part B and didn't sign up. So when someone says to me, wow, do I need Part B? I say, absolutely. And there are ways, however, that you can sign up for Part B under late enrollment. And that is if you're still working or you're covered under your employer, your own or your spouse's. There's a special enrollment period that you can sign up for B with no penalty. What you do have to do, though, is you have to have proof from your employer or your spouse's employer that they will provide a letter verifying that you've had what's called credible coverage. So you're not just ducking out, that you've had credible coverage and then you don't pay a penalty. So what's challenging about Part B, and I learned this a few years ago, and this is a really important tip for you all to know, Part B is tied to your income. So the amount of money you pay is tied directly to your income. When you first sign up for Part B, if there's any newbies in this group, your charge for Part B is going to be based upon a 2-year look back, which means that if you retired and you're making less money today, your premium is going to be based upon what you made 2 years ago. Now, for most people, not everybody, obviously, but for most people, their income goes down when they retire. So if you look at the bottom of this slide, and I put a link in there Social Security has what they call a life-changing event form. So what you would do is you would fill out the life-changing event, and there's about 7 categories. And basically, you send that through to Social Security, who in turn contacts the IRS. And they say, oh yeah, she doesn't really make $100,000 a year anymore. She only makes $50,000 a year. As a result, the premiums for Part B get lowered. Now, I know this chart is a little hard to see, but it's important to just visualize what this means. If you look at the left-hand column going down, that's the amount of income that the IRS and Social Security look at when they're deciding on your Part B premium. So if you are an individual and you make less than $88,000 a year, go clear over to the right, your premium's $148.50. If you're married filing jointly and you make $176,000 or less, it's $148.50. But you'll see as it goes up, if you make over $88,000 up to $111,000, that premium's now at $207. So by all means, excuse me, if you have an opportunity to go back and look to make sure that you're not being overcharged for B, that's a really important thing to do, and important to tell other people who are signing up for the first time about that life-changing event form. So why is B important? Well, B pretty much covers, I mean, hopefully, God willing, most of us will stay out of the hospital and stay out of rehab, but most of us are going to be needing durable medical equipment and home health and doctor's visits and physical therapy at some point in our lives. And it's Part B that pays for all of those. The other thing that Part B pays for, and it's becoming more and more and more prominent, is the biologics, the new high-tech injectable drugs that you see advertised all the time on television. I had a neighbor who had a severe case of psoriasis, and they were treating that psoriasis with a monthly injection that cost $14,000. So you can imagine that you would not want to be paying that amount of money out of pocket. And the other thing is, if you end up in a hospital and you think you're an inpatient and you find out really you're in observation status, it is Part B and your Medigap plan that would be paying for those charges. And I'm going to do a special presentation. I think it's in January. It's one of these 5 series dedicated just to what is the observation status, how do you know if you're in it, how do you pay for it, etc. Here's another thing that seems a little obscure on the face of it, but it's really important to understand this, because over the past, I would say 5 to 7 years, there have been numerous physicians and physical therapists and other practitioners who simply say, I'm not going to take Medicare anymore, and you've got to go find another doctor. So there are 3 categories of healthcare providers that participate in Part B. The first one is sort of the basic, generic, always have, always will physician, and they're categorized as quote unquote accept assignment. And what that means is they accept Medicare. You show up at the doctor's office, you have your visit, you may have your copay because you've got a supplement to pay the 20%, but they take what you have and they bill Medicare, and that's the end of the billing. There are those, however, who've now chosen to be what's called non-participating. And these are individuals, be it physicians, therapists, etc., who have not agreed to accept Medicare covered services. So what happens at the time you're checking out is you will pay 100%. You write them a check or give them your credit card. Then they will submit the claim for you to Medicare, and you will get reimbursed by Medicare. But as I assume that you will probably guess, what Medicare reimburses is nowhere near what the charges are. So the non-participating has implications for out-of-pocket costs for you. Now, I would say now, having been in healthcare my entire career, that the reimbursement for Medicare is really pitiful. The amount of time it takes to fill out the claim forms is equally pitiful. And then the turnaround time to get paid. So there's been a huge movement among the medical community moving toward becoming either non-participating or, in the last case, these are providers that are called opt-outs. They accept no Medicare, no insurance of any kind. And what that is you, when you begin to see them, a doctor, physical therapist, whatever, you basically sign what is considered to be a contract or a form. And what you verify is you will not attempt to get reimbursed for this. So if the physical therapist charges you $200 a session, you pay $200 a session, and you do not submit paperwork to anyone or any insurance. That's what you've agreed to. Okay, let's talk about supplement plans. I'm sure that a number of you have them, but given that open enrollment starts in 2 days, I thought it was well worth spending a little bit of time here. We all know that because Part B has co-payments, I mean, 80% is great for Part B to pay for, but there's still 20%. And 20% of a $200 bill is a substantial amount out of your pocket, especially if you're paying it on a regular basis. So these Medigap plans, they are private insurance companies, but they get approved by Medicare to provide the service. So a couple things to consider when you're choosing, or if you're thinking about changing plans. It's really important when somebody first signs up for Medicare that they sign up for a Medigap plan if that's what they're choosing to do. And they need to do that within 6 months. Because if they don't sign up when they're first eligible, a couple of things can happen. The companies can charge you a higher premium. They can subject you to something called underwriting, which in the insurance world means that they can charge more for someone who has a pre-existing condition, or you may not find a company that's willing to sell a policy at all. What they cover, as we said, is the co-insurance for Part A, the rehab co-insurance, and what people really spend time looking at when you look at these supplement plans, and there are a boatload of them that are available. Basically looking at, some people can afford, maybe they have assets, but their income is rather low. They might look for a plan that has a lower cost premium or with a higher deductible. It's usually one or the other. And the reason being, if somebody's in pretty good health and doesn't really anticipate going to the doctor and needing care, they would likely pick one with the lower premium. And then if something did happen and they needed the service, then they would be paying a deductible. And if they found that it was going to be a chronic thing the following year in open enrollment, they may switch plans. But a really important piece of this is anybody who does any foreign travel at all absolutely needs to have a plan that covers foreign medical care if you're in a foreign country. These plans are pretty bare bone, but if you fell off a cliff someplace, that you were climbing a mountain somewhere, if you have a Medigap plan that covers foreign travel, it would pay for the air ambulance, it would pay for the emergency room costs. And I'm sure if you're going to be climbing a mountain, you've probably bought some private travel health insurance, but just to be sure. So if you were going on the Medicare.gov website, this is what you would see if you were looking for a Medigap plan. So it would say, find a plan that would work for you. And then what you would do is you lop in your zip code and then you'd hit start. And here are samples of what you would see. I would tell you right now, one of the most comprehensive plans out of all of these, and it's A through N at this point, and I made a chart a little bit further down. A through N, plans F and Plan G are the most robust, cover the most things, and you'll see the chart what I'm talking about. But those are the two most popular plans. If, however, if you're eligible for the first time for Medicare in January 1st of 2020, you no longer have access to the F plan, so you have to go with G. But be that as it may, they both provide equally good coverage. There is a nuance here, which is going to be really important. And again, I did a screenshot, so it's the best I can do, but I made another slide for it. if you look at this AARP United Healthcare, and you look on the right-hand side, it says community pricing. And community pricing means that the premiums are the same no matter how old you are. So they're not going to go up as you get older. The only way they would go up is if you were, if there was inflation, then it would go up for everybody. If you look underneath there, the Banker's Life. Banker's Life has something called attained age, and that's where premiums are lower for younger buyers. But as you get older, you pay more money for that. Or I'm sorry, that's a mistake. They're cheaper if I'm 65 and I buy a plan. If you're 67 and you buy the same plan, you're going to pay more money because you were older when you first took the plan. And I think what's challenging about all of this is that if people are choosing Medigap plans, there is so much to consider that 99% of the people would never even know to look at community pricing or attained age pricing. They just would, you're worried about premiums and deductibles and whether your doctor takes the plan. So I just call that to your attention because it's a big money saving issue. And the third one of those is the age issued. The price you pay, that's wrong. The attained age one, that is where it gets older. As you get older, the price goes up. So the three are community pricing. There's no age requirements on that. It's the same charge for everyone. Attained age is where it's based upon your age when you purchase it, and it goes up as you get older. And then age issue is that charge you more money when you first buy it on the front end. So here's a better look at what we did a screenshot on. You'd see the AARP United Healthcare, and of course they want you to either call them or visit their website, but you'll see that what would have been up in the right-hand corner that you probably couldn't see is community pricing, and the same with the Banker's Life. It's a similar thing. Now, here is the chart, again, that you would find on Medicare.gov, because there's no way, of course, that you could read it on the screen. But Plan F and Plan G, if you're looking down there, they really pretty much cover everything. If you're looking at some of the other ones, you'll see where you're seeing no, like a Plan K only pays 50% of Medicare coinsurance and only 50% if you need 3 pints of blood. So on the Medicare.gov website is where you would see this chart. And this is enormously helpful for people as they're making their decision. And at the very bottom, you'll see what you probably can't see. As I said to Erica, there are huge advantages to Zoom, but there's also some disadvantages to Zoom. You can't get things as big on a screen as you want to. So that would be the foreign travel one. So I really encourage you to go to Medigap, to go to Medicare.gov and tool around and look at these, especially if you're considering the fact that you might want a different plan than what you have now. So the question is, do you have one and do you want to switch? Well, if you already have either a G, we just talked about this, G or an F plan. If you have neither of those, then you can pick, if you're not just turning 65, you can pick an F plan. But if you're just turning 65 and signing up for the first time, you'll have to stick with the G plan, which once you look at the chart in real time, you will be able to see that they're really, the only thing that, the only thing that's different is that Medicare no longer allows these companies to pay the Part B deductible. But the Part B deductible is only $148, so it's not a huge deal. But again, I put a website link on there in terms of how it works with other insurances, and be sure if you're doing foreign travel to make sure which whenever you pick has some foreign travel coverage. So let's spend a little time on the Medicare Advantage plans because they're not exactly new, but a huge boatload of money has gone in to companies who are now competing to provide care under the Medicare Advantage plans. So what are they and why are they all over TV? Well, I don't know if any of you have seen the commercial, but there's a former Pittsburgh Steeler named Joe Namath who's advertising Heaven only knows which one. And I'm from Pennsylvania, so I recognized him and I knew he was a former Steelers player. But I said to myself, surely to heavens, they can find somebody who's a little bit healthier looking than this old football player, because he would not be somebody that would make me sign up for a Medigap plan. These are considered hybrids. These are plans that are sold by private companies, and they combine what would otherwise be a Medigap plan and a drug plan. They coordinate the care on behalf of Medicare. So if somebody has a Medigap plan, they no longer need a supplement, they no longer need a D. And this is the insurance card that you would hand when you got service. You do, however, need to have Part A, and you do, however, need to have Part B. You have to have both of those to sign up for one of these. So the advantages are that there's a one-stop shop. I mean, you have one card and you hand it in and you're not fumbling in your wallet. To make themselves more competitive, they're literally knocking each other over with all these extra things that they have. They're now including vision and dental and home delivered meals. If you've been in the hospital, they'll do home delivered meals for 2 weeks. They want to keep people out of the hospital. And the gym membership, something called Silver Sneakers. So if you are interested in one of these, you're still paying your Part B premium, and you are paying for this plan too, but you're not paying for a separate Medigap, and you're not paying for a separate drug plan. So the models of care for these two are one or the other. There's only two models of care for these. One is an HMO and one is a PPO. So here, by definition, an HMO requires that you stay in their network of providers to receive the care. A preferred provider organization, on the other hand, the patients still have a network of providers, but they're not restricted to just those providers. You can go to anywhere you wish. And in general, the copay and the deductible, if you go out of network, is going to be higher than if you stayed in the network, but you have the option to do that. So let's talk more about the HMO model, because it's not a model that a lot of people are necessarily familiar with. I'm going to use Kaiser. If anybody has had Kaiser as an employee coverage or have it now, Kaiser was sort of the consummate first HMO plan, and they have it down to a science. But HMO is based upon a network. So for example, they would have a contract with Suburban, or they might have a contract with Sibley, but they have contracts with doctors and hospitals and other healthcare providers like physical therapists, psychologists, etc. And these healthcare providers will take payment based upon their contract with the HMO. The important part of an HMO model, because you have to stay in those networks, is you are able to select a primary care physician. But again, the primary care physician has to be in network. One of the downsides, and there's advantages and disadvantages pretty much to all of these. The HMOs cost less than the PPOs in terms of premium. The other thing it's frustrating for people who have an HMO is if they need a specialist or they need a referral for a second opinion, oftentimes they cannot get that. If it's not an emergency, they must stay in the HMO network or it's not covered, and they end up paying out of pocket. And some people choose to do that anyway. Just given the richness of the healthcare providers we have the benefit of having here with all the academic medical centers, a lot of people say, no, I want a second opinion from so-and-so at Georgetown or so-and-so at GW, and they will pay out of pocket for those. So again, the advantages are if you're budget conscious or if you really don't anticipate many doctor's visits, these are cost saving. They have lower premiums and generally much lower out-of-pocket costs. Your prescriptions are going to cost less. You don't have to file a claim form. That's already taken care of, because the person that you're seeing already has the contract with the HMO, and so you're not doing any any paperwork at all. And you have the assurance that that primary care physician is going to advocate for you and help to coordinate and manage your care. So the disadvantages, again, you have to stay in network. And I will use Kaiser again just as an example, because that's probably I think they were the original HMO. Kaiser has a huge presence in the Pacific Northwest and in California, and they have a very strong presence in the Mid-Atlantic. But if you are somebody who spends several months a year in Florida, an HMO is probably not going to be what you want to pick, because it is highly unlikely that there are medical providers that are in that HMO that are in Pinellas County, Florida. If you fall and break your leg, the ambulance will probably be covered and the emergency room would be covered, but no follow-up care would be covered if the physicians and the hospitals are not in your primary network. So I really encourage people, these are attractive because they cost less, and all the reasons that I just said on the other slide, all the reasons that you want to possibly have them, because they're lower costs all the way around. But the trade-off is going to be, if you are somebody who spends any amount of time out of this Mid-Atlantic region, you really need to think about this. So PPO. A PPO is like just having your choice, basically. PPOs also contract, though, with a group of healthcare providers and hospitals. So if you go to any of those, you still have a copay and a deductible, but it is substantially less if you stay within their network. You have a choice of any doctor that you want to see, and that's especially important for people who've had the same primary care physician their whole life, and they don't choose to change doctors. A PPO would be more attractive to them. Again, flexibility. If I want to get physical therapy at Georgetown and I don't want to have to go to a particular hospital or private, I can go to a private practice, or I can go anywhere. But I may have to pay more if I go to the physical therapist in a private practice, but at least the care will be covered. And again, a really important thing is being able to visit specialists without having a referral. And that is a big deal. You want a second opinion on something, you want to see a specialist, you don't need approval to get, and you can go to out of network specialists. Okay, disadvantages. As I said, there are both. There's higher premiums and you pay higher out-of-pocket costs than you would if you had an HMO. You have more responsibility for managing your own care, because the primary care physician is not being reimbursed to manage your care in the same way that they are in an HMO. In many of these plans, you have to pay your whole year deductible upfront before your coverage begins. So that's another consideration. And that amount of money is going to be determined by whatever the plan is. And if you go out of network, you're likely to have to pay for your copay and the full cost of the medical bill, and then you file the claim for reimbursement, but you will be reimbursed for the whole amount. So the disadvantages of all of these, they're sold. This is pretty interesting, and I want you to stay with me here for a minute, because when you really study these, it's really pretty shocking, actually. These Medicare Advantage plans are sold according to zip codes. So not all plans are available in the same city or even in adjacent neighborhoods. Most of the plans and most of all the plans that are currently being offered are HMOs. And that means, again, if you take one, that you're limited to the providers in the network. And again, if you get one of these Medicare Advantage plans, you very well are potentially giving up your healthcare providers that you normally would see. And I'm going to show you a really good example. These plans cherry pick. Remember, these are private insurance plans. They're approved by Medicare, but they're not Medicare plans. So they cherry pick. They offer more lucrative plans in higher income zip codes. And many of the plans offer fewer benefits and higher premiums in zip codes, perhaps where the median income is less. And here's a real-time example. I just arbitrarily, out of the clear blue, I just picked Benning Road Northeast, for those of you who live in DC. I've never been to Benning Road Northeast, so I don't know why it popped into my head, but it did. If you're to look at the Medicare Advantage plans that are available in zip code 2002, there are 11 Medicare Advantage plans. Eight of them are HMOs, only 3 are PPOs, and 2 of them are what's called a special needs plan. And the special needs plan are for low-income people who are eligible for both Medicare and Medicaid. And they're called Quimbies and Slimbies and all manner of anachronisms. If you look at the zip code, if you look in zip code 2007, which is Georgetown, Foxhole Village, sort of upper Northwest, basically, there are still 11 plans that are offered, but 5 of them are PPOs. 5 of them are HMOs, and there's 1 special needs plan. So we just said premiums are higher with the PPO, but they give you more choice. And so I think you can see that it differs from one zip code to another, depending upon where you live, what you have to choose from. Couple more downsides, if you will, to the Medicare Advantage plans. Companies can change benefits every year. They can change the premium every year. They can change the provider network every year. They can increase the coinsurances and the deductibles, and they can change the pharmacy networks. And again, that is subject to they're driving the bus on this. And so all of those or any of those or none of those might be able to change. They can also change most of the, I don't think I said this before, but most of the Medicare Advantage plans have drug coverage. And you would probably, if you're going to pick one, I would strongly encourage you to pick one that does have drug coverage. But if you have one with drug coverage, they can change the medications on the formulary, decide what they're going to cover, or they can move it to a higher tier, which then is more expensive for you. So, in summary, the plans are available by zip codes. They're all private insurance companies, but that Medicare pays basically to run the programs for them. And that if you choose a HMO, you do have to be, you're basically limited to the doctors and the hospitals that are in that plan's network. And just want to say again that they're a hybrid that combine a Medigap and a drug plan, but you still have to have A and B, and you still have to pay your Part B premium. If you're signing up for one of these, it's really important on the front end. If you're signing up for one with drugs, which I really encourage people to do, please verify in the front end that your drugs are going to be covered. Again, many of these are trying to attract new customers, so they're offering vision and hearing and dental. Of course, we'd all like to have that paid for. And most of these have a limit on the out-of-pocket costs. A question that came up when I was working one-on-one with a client was, well, what if I pick one of these and I decide that I don't like it? Well, Medicare has allowed for the fact that somebody might be attracted to these and decide to change. They might want to change to a different plan. They might say, well, this is too complicated. I really want back to the original Medicare. For that to happen, you can do that. There's a special enrollment period that goes from January 1st to March 31st, or you can wait till open enrollment the following year and there's no penalty. You can go back to buying a Medigap plan and a drug plan, so there's no penalties. If you say, I just don't want to be restricted by all of these. Or on the other hand, you may love it and it's not a big deal, but you're not in it for life, I guess is the point. There's a strange red line down the middle of my screen and I can't figure out what it is, so I'm sorry. To get out of one of these plans or to get into one of these plans and change, you basically would contact Social Security. And the reason you contact Social Security rather than Medicare is that Social Security actually manages Medicare. And most people probably don't know that, but the policies and procedures and for Medicare are an agency called CMS, which is a federal agency. It's Center for Medicare Medicaid Services. and they drive the bus in terms of what the policies and procedures are, but it's the Social Security Administration that actually administers it. So you would contact Social Security, or you could contact Medicare directly. And then if you are in an Advantage plan and decide you don't want it, you have to actually disenroll from the Medicare Advantage plan to go back to original Medicare. Again, the timeframes, excuse me, are that special enrollment period from January to March 31st or October 15th, which starts Friday. Every year, the open enrollment period for Medicare, excuse me, is October 15th through December 7th. I want to do a sidebar for just a minute. I was working with somebody who has federal employee benefits, and I noticed that several of the federal plans like Aetna and Blue Cross, sorry, have Medicare Advantage plans that they are offering. And I think that's new this year. And in those Medicare Advantage plans offered under the federal employee health benefits, they will actually reimburse people for up to $900 a year to pay for their Part B premium. But they're requiring people to enroll in Part B, but they will reimburse the person with a plan up to $900 a year to help to offset the cost of B, because they require somebody be in B in order to get the coverage from them. So how do you decide? Well, there's a lot to choose from. You know, the choice of providers is big with some people, whereas Medicare Advantage, you have to stay in the network unless you go with the PPO. Under the Medigap plan, if you're going that route, you need to weigh the cost. The Medicare Advantage are generally less expensive. The Medigap plans are secondary to Medicare. That means that Medicare pays first, and then the supplement pays whatever the remaining balance is. Whereas these Advantage plans are totally separate from Medicare, and all the benefits come directly from the plan, not from Medicare. The plans themselves bill Medicare. On the Medigap side, you need to buy a drug plan, whereas with Medicare Advantage, drug coverage is included, as well as the other perks. And with the Medigap plan, if you choose one for foreign travel, that's important, whereas the Medicare Advantage plans, you just have to consider the geography, because all of them the likelihood of covering someplace far away is pretty unlikely, basically. Okay, so let's talk about Part D prescriptions, because some people will decide they have no interest in Medicare Advantage. They want to stay with original Medicare, and staying with original Medicare means that you're going to be buying a drug plan. Theoretically, Medicare D is voluntary. But if you decide not to join a plan when you're first eligible and you don't have some other private credible plan, and you decide later that you're going to be having to take medications and deciding that you want to sign up for a Part D, you will be paying a really substantial premium for the rest of your life. So my recommendation to people is think about Medicare D as you would car insurance or a AAA membership. You may never need to have your battery changed. You may never need to be towed someplace. You may never need to have a flat tire for your car. You may never get into a collision. You never need it. But if you wait to apply for Part D, until you think you need it, the premium is just astronomical. And it's some very convoluted formula that it is 10% of the median charge for whatever it is in that particular year times every single year that you were eligible for it and didn't get it. So my advice to people is, if you don't take any drugs, or you take some really cheap blood pressure drug, pick the very cheapest Part D plan you can find, enroll in that, and then just basically bite the bullet and just stay with it. Because at some point, I think just chronologically, as we get older, we are more likely to need some kind of medication, be it blood pressure, be it heart statins, be it anything. And it's a whole lot easier if you're paying $20 a month for something. I mean, like I said, think about it like car insurance or, or AAA membership. It's better to have it because the cost is going to be so outrageous. And the new biologics that are out there now, like I told you about my neighbor who needed $14,000 a month treatments for psoriasis, it is frightening how expensive the drugs have become. Just basically, one thing I would like to advise people to do, sort of my last bullet point. I'm sorry, it was on a soapbox a little bit, but I just have seen too many people pay through the nose if they end up being prescribed a drug that out-of-pocket costs are ridiculous. And the premium, I mean, the late enrollment premium is so substantial. But my recommendation to every person is that every year at the time of open enrollment, you actually go in and you actually look at your drug plan, because you need to make sure that your medications continue to be covered, and you need to be sure of what the coinsurance is going to be. Because under a Part D program, the pharmacies, not the pharmacies, the drug plans themselves, they actually have the opportunity to change what they cover every single year, and they can change the amount, the tier that they're on, which changes changes the amount of money that you pay. So whether you're in a Part D plan or whether you're in a Medicare Advantage plan with drugs, I think it's imperative that you check every year to make sure that it's still the right drug plan for you. I have seen so many people it's annoying. It's a pain. You're like, oh yeah, whatever, I'll get around to it. We get very complacent. We stay with what we have. But my advice is, since you're in open enrollment season, is to take a look at the specific drugs, find out what they're going to cost you over a whole year, because you're basically going to be comparing to make sure that you're in the right plan for you at a price that you can afford. The question is, what happens? What happens if it does change? It's very stilted to the pharmaceutical companies being in charge here, because the pharmaceutical companies can decide with a 60-day notice that they're going to change their formulary. And that means that they could say, well, we're just not going to cover this anymore. Or that could mean that we're not going to have it at tier 1. It's a $10 copay. We're going to make it a tier 4, which is a $35 copay. And keep in mind, if that happens during the year, you have no choice. I mean, you could drop it altogether, but then you'd be going back and buying a new one in open enrollment and paying the price. But you have no choice. I mean, you basically have to either suck it up or wait to open enrollment and find a new plan, because they make the decisions. And I think it's really unfortunate that they have to give you a 60-day notice, whereas you have to wait, theoretically, 10 more months in order to change the drug plan that you have. So what if that happens to you? Because I know it happens to people all the time. Well, you can file an appeal. And I would suggest that if you are personally filing appeal, it would be really good to have your physician write a letter to go along with yours, because it's going to carry more weight, to be honest. You could go to your physician and you could ask them, is there a different drug? Because, this one's not being covered. You can look at the drug companies. The drug companies, if you watch any amount of commercial TV with all these new really, really high priced drugs for everything from living longer with breast cancer and lung cancer to, psoriasis and whatever else there is. They also, at the end of each commercial, they will say, if you're not able to afford your medication, AstraZeneca will be able to help. And those plans are really, really attractive, and they can do, they won't do it, I don't think, to infinity, but they're very appealing, and because they want to sell their drugs, and then they look very benevolent, and they get to write those things off as business expenses. So it's not like they're being totally benevolent, but it is important to take advantage of that. The other option, and I don't know if everybody knows about this, but if you haven't heard of this, it is called goodrx.com. And I think most people know about it, but if you don't know about it, it is just an amazing resource. What it is you go into the website, goodrx.com, and you put in your zip code, and then you put in the name of your drug, the frequency with which you take the drug, and the strength of the drug. And it will pull up 7 or 8 pharmacies in your zip code. So it would pull up, let's say, Rite Aid and Safeway and CVS, and it may even pull up Walmart, depending upon where you live. And it would show you the amount of money that you would pay for that drug in each of these pharmacies. If there is a downside, which is hard to imagine that there is, but the only thing that it doesn't do is it doesn't allow the physician to send this through with electronically. You actually have to have a physical written prescription. But you're on GoodRx, you find your drug, you say, wow, Safeway in Georgetown has the lowest cost. You print out the form from GoodRx, you get the written prescription from your doctor, you take it to the pharmacy, whichever pharmacy has the lowest price that you choose. You give it to them, they put it in their system. They keep it in their system. So all the refills get covered at that same price. All of the renewals get covered at that same price. And I would tell you, in so many cases, the actual GoodRx cost is less expensive than the copay with a drug plan. I mean, not always, but often it is. These are really good. I have a dog that takes drugs because she's a little wild and crazy. So I get her medication through the GoodRx program. People who have diabetic dogs can get you can tell I'm a dog person, but the people who have diabetic dogs can get their insulin through GoodRx for their dogs. Some of the medications that your insurance company might not pay for, and they might just not pay at all. Using GoodRx is a really good resource for that. And I guess last but not least, if you had to pay for the full cost of the drug. So in a nutshell, that's Medicare 101. Erica, what is the best way for us to get questions answered? My last slide is my email address and my cell phone number. If subsequently that you have comments, you want to give me some feedback or questions, and I can leave that on the screen. Erica, what shall we do as far as questions are concerned? Do you want people to raise their hand? What's the best thing for us to do? Erica, I think you're muted. Hang on a minute. Okay, I think Eric is on the phone. So let me give her a minute to figure out how we should. Let me stop sharing so we'll get our faces. Okay.
There are some questions in the chat.
Okay. All right, we can do. Thank you, because I know not everybody does. If you do, okay, I'll read out loud and answer them out loud. If you do not do Medicare Advantage, are there other choices? Yes. The traditional Medicare is A and B, and you can pick a Medigap. You can use the terms interchangeably. Medigap and supplemental plan are the same thing. You would get a supplemental Medigap plan, and we went through those slides that I showed you, kind of the things to look for on that chart, or and a drug plan. I'm TRICARE eligible, and so that's TRICARE for life. Is there any reason for a Medigap plan? I am not an expert in federal health benefits, but I am sure that if you called whatever the provider was, they would answer that question. I don't want to go there because I don't want to give you the wrong answer. I don't think you need a Medigap plan. I think the TRICARE is fully comprehensive, but again, I would ask the question of whoever it is your insurance is with through TRICARE. Okay. Do I understand correctly that if I enroll in the Medicare Advantage plan, it could replace both D and F? No. If F is a supplement plan, so if you build a block, if you build a 4-part block, you have A, you have B, you have a Medigap plan, and then you have a drug plan. If you go with a Medicare Advantage plan that has drugs, you don't have to have a Medigap plan, and you don't have to have a Part D plan. So the F that I was referring to is one of the supplemental plans. It's the Medigap plan. So you would not have a Medigap plan if you picked a Medicare Advantage plan. Because the Medicare Advantage plan, you're going to pick one that has drugs or that offers drug coverage. I'm sorry. So you'd have Medicare Advantage plan, which would be both the drug plan and the equivalent of the Medigap plan. Okay, be careful with drug comfort, and he's offered to help if you're not eligible for Medicaid, but can afford full price. Someone is saying that if you're not eligible for Medicaid, I guess that means if you're not terribly low income, that you can't afford the full price and they won't really help. So I'm not sure who Margie is, but Margie, Margie, do you want to? Are you still on, Margie? Do you want to unmute yourself and say something about that?
Yeah, I can just attest that at one point my Crestor was not covered by my insurance, and the other generics didn't work. And so I did call AstraZeneca, and I basically fell between the cracks, and they wouldn't, that plan didn't help. So I just wanted people to be aware.
Okay. Thank you. That's good feedback. Okay. Karen says, I have an Advantage plan with prescription and is a credible Part D, but the premium is paid through. I'm sorry, Karen, if you're still on here, can you elaborate a little bit? I'm not sure I understand the question.
Yeah, I just went on an Advantage plan.
Okay.
And my premium with the Advantage plan is paid through the company providing the plan. But I noticed for the drug, the Part D, so the Part D plan is considered a credible Medicare Part D plan. And the premium is actually billed through the government and not through the private Advantage plan. So I thought that was interesting.
So
and it's IRMA rated.
Okay.
So
So you're saying that the Medicare Advantage plan offers a drug plan. Your offers a
Yeah.
drug plan, but you're paying separately for a Medicare D plan.
well, it looks like under the Advantage plan, I'm only paying the premium for the for the Part B stuff. But the premium for the D, see, if you don't understand it and I don't understand
Yeah.
it, I'm
Well, I
getting
know.
getting billed through the government for the Part D part.
Okay, which
It's
tells
offered
me,
through the Medicare Advantage plan.
okay, what that tells me is that you picked a Medicare Advantage plan that didn't include drug coverage. So you are having a Medicare Advantage plan, but you're paying separately for a Part D drug plan because the one that you chose didn't include drugs.
Mm-hmm.
And so you're paying separately for the Part D. There are the Advantage plans which include D. So their premiums are probably higher, but you're paying one premium and it includes the equivalent of it functions as if it's a Medigap plan and a drug plan together. So whichever one you chose, were you willing to share which one you chose?
Yeah, it's a Aetna Advantage. That my company provides, the company I retired from.
Okay, so they pay the whole premium.
Well, actually, no, it's more complicated than that. It's Express Scripts that administers the drug.
Okay. Okay.
So it sounds like it's two separate plans.
Yes.
Yeah.
I would say I'm 100% sure, because if those drugs, if you're being billed separately, and what Karen was saying in the IRMAA, we didn't even really talk about that because it's such jargon, but when we talked about how expensive B was, the premiums for B tied to an income, the premiums for D plans, and if I ever do this again, I'll include that in the slides. Karen, thank you actually for reminding me, but Part D is also income-based. So if you remember that it's the same chart, I mean, it's the same income amounts if you have a drug plan. So if you're paying over the basics for B, you're going to have that same income overlay for the drug plan. So thanks to Karen. But I'm sure, Karen, that's what it is. The company said to you, we'll pay the premium for Medicare Advantage, but you pay your own premium for G. So
Yeah.
Right.
What I
So
found confusing is that in all of the communications that they've sent me, all of this material that they've sent me, they never just explicitly stated how I pay for these two things, you know? So it's very confused, makes it more confusing.
Well, all of this is so confusing. You need a PhD in Medicare just to understand it. I'd said to Erica, as we were kind of waiting for people to get on, the thing that always strikes me about this is if you had the least bit of visual impairment or cognitive impairment, or English wasn't your first language, how do you do this?
Yeah.
I mean, this is just impossible to do, and it takes so much time to, plow through and look at and decide what you need, etc. So thank you so much for bringing that up.
Okay, thanks a lot. That helped clarify it for me.
I think that's all that are in the chat room at the moment. We've answered those. Does anyone want to sort of raise their hand, and I'll move around with the little cursor here. Mark. Hi, Mark. Mark, you're muted, so I can't hear your question. All right. Unmute. Oh, Mark, you're muted.
Oh, it was a clapping hand.
A clapping hand. I'm sorry.
A clapping hand.
I thought it was a raised question.
Well, I think we should all be giving you a clapping hand.
Oh,
thank you, MaryAnn. You have made us all feel so much better prepared to tackle all of these Medicare decisions, and it is so complex. And I want to alert everyone that MaryAnn will be joining us again on November 10th to talk about advanced planning, and we would love to have you join us. In the meantime, if you're looking for something a little bit later, on the 20th next week, we have Gordon Peterson joining us to reflect on his time in news. And then the following week, author Jack Riggs is going to be in conversation with Greg Mize, talking about his book, High Tension, talking about how FDR brought electricity to the nation, which should be interesting as well. But thank you, MaryAnn. This has been fabulous.
Thanks, everybody. Nice being with you today.
It has been great. Could you put the slide back up with your contact information?
Sure.
Or else just dictate it to us?
1 second.
Thank
here.
you.
Yeah, there we go. So Erica, thank you for co-hosting.
I'd
Thanks,
like to
everybody,
make,
for
Little
being here.
technical issues at the end, but we'll ignore those.
I
I
have
didn't-
a comment that if you try and do this, you could end up in the hospital just trying to figure it all out.
Well, it is daunting. I mean, daunting. And there's so many moving parts. And I think, Karen's question, for example, was perfect question. Part of it's paid for and part of it's not. And yet you're paying for a separate drug plan. And so again, I mean, it's just, I don't think you can make it more complicated than it is. So that's a term about it's not rocket science does not apply in this case. So, well, thanks everybody for joining us today. And I hopefully will get back together again in November, where we're going to talk about advanced care planning. Hopefully a little easier to work on and think about than this is. So thanks so much.
Thank you.
Thank you.
Here.
Hi, Erika.